When he was practicing medicine in Colombia more than a decade ago, Juan-Nicolás Peña-Sánchez never saw one single person diagnosed with inflammatory bowel disease, not in Colombia. But when he came to Canada, that changed. Canada now has one of the world's highest rates of inflammatory bowel diseases, or IBD. Crohn's disease and ulcerative colitis are the two main types. These are diseases that are linked to our genetics, to our westernized diets, our lifestyle, to our urbanized culture where a lot of us sit a lot of the time. Dr. Juan-Nicolás Peña-Sánchez is finding ways to innovate in healthcare and to improve access to specialized care. And he's our guest today on Researchers Under the Scope. Hi, I'm your host, Jen Cannell, and today we're recording this at the E Wing of the Health Sciences Building. It's a beautiful summer day, and our guest is Dr. Juan-Nicolás Peña-Sánchez. Originally, he's from Colombia. He then moved to Europe and is now at the University of Saskatchewan's Department of Community Health and Epidemiology, where he's an associate professor. Hello, Dr. Peña-Sánchez. Welcome to Researchers Under the Scope.
Hello, Jen. Thank you so much for inviting me.
Back in Colombia, I know that medicine was an avenue you pursued, but it wasn't just you and your family. Your father was also a physician?
Yes, my father, my stepfather, who is like my father, he is a physician. He used to practice as an emergency doctor, providing primary health care. So when I started my training as a physician, I was inspired by my instructors, seeing my father. I used to go with him, sometimes in the shifts with him, to learn and shadow him. I was inspired by his way of practice, connected with patients, being there to listen and really help, finding ways how to treat and be well, especially the patients that he used to see were not in the ideal situation, low socioeconomic status. And through the training, I really enjoy medicine, although a few things started changing through my training process.
What changed?
First, that I was quite passionate about health promotion, health prevention, healthcare systems, healthcare management, how to address the needs of equity-deserving groups, and how to innovate healthcare. A little bit before I started my training, there was a big reform in Colombia back in the 90s, where the healthcare system changed completely because the healthcare system was quite fragmented and most of the population was not covered.
Oh, so it would be a big expense or like a big problem if they needed to seek healthcare.
Exactly. So many didn't have access, and those who have access wasn't the optimal. And only those with income could have a private insurance and seeing a physician through out-of-pocket payments. So it wasn't the ideal healthcare system. There was a need for a reform. Okay. When the reform came, then many things happened. Under the influence of multilateral organizations like the World Bank and the International Monetary Fund, where numerous nations undertook reforms in the 90s and the 80s based on market models in their social sectors, including healthcare.
Like neoliberalism was really sweeping through by the mid-90s.
Yes.
It's a big force.
That's right. And there were big changes. Within those changes, yes, the coverage increased dramatically, but having a coverage doesn't mean having access. And the healthcare system was structured into two tiers: those who had capacity to pay and others who received funding or subsidies from the government. So in a country with inequities already in place, you create a healthcare system that added more inequities.
They've amplified them.
Exactly. And that's what I was observed. In addition, there were new actors like the health insurance companies. They were not there with that important role before. And that changed the way to practice medicine. And I observed that in my father, his colleagues, and many of my instructors that were dissatisfied about how to practice medicine. So instead of being able to say, I will see a patient in 30 minutes or in an hour, depending on your practice, you were forced to see patients in about 10 minutes. So that was a big change, how to organize your practice first. Second, the way you practice and how you can manage resources was quite managed at a micro level. So the number of referrals you can make to a specialist as a primary healthcare physician was controlled, the number of prescriptions. So there was a big change in the professional autonomy, which really affected many physicians in Colombia.
I have heard American doctors complaining about how insurance companies seem to be determining how they'll treat their patients. Did it feel similar to...
Yes, quite similar. Actually, the healthcare system in Colombia was inspired by some ideas in the healthcare system, the insurance system in the United States, and also the model that was in place in Chile.
So what happened for you then? Where did you turn and say, okay, maybe I'll start looking more closely at public health?
That's right. So I didn't want to practice within that environment. Actually, when I started, I practiced more working with NGOs and private patients that I usually did home visits. So it was different. And also I was quite curious to understand that since if you're going to work in a healthcare system, you need to understand your market, the healthcare system, because you're a citizen of the healthcare system and you're going to practice within that system. Before leaving Colombia, I worked with one of the health insurance company as a medical auditor. So those who are regulated, and I wanted to understand all the perspectives within the healthcare system. And with that experience, that was the last experience when I decided to go to Europe for my European Masters in Public Health.
That's actually really smart to see it from the insurance company's point of view.
And I learned a lot.
Oh, yeah.
How they work and what are their objectives. But it was quite interesting because in this position that I had, they have a different vision. That is, was not only to regulate by limiting resources, actually how you can improve quality of care to reduce cost. And that was quite aligned with my vision of healthcare. So it was very enlightening experience, and that pushed me definitely to continue my training, graduate training.
Well, and for your training, in terms of your Master of Public Health, in terms of your doctorate here in Saskatoon, what did you choose to really hone in on and study?
So, because these experiences that I had in Colombia, it was quite interesting to understand and study well-being and motivation of healthcare providers. And I started with physicians within my master's. In Spain, with a group of collaborators, we adapted and validated a questionnaire to measure career satisfaction of physicians in Spanish, and we also evaluated the factors associated to higher and lower levels of satisfaction. Interestingly, we identified that in Spain, in Andalusia, where we completed this study, that international trained physicians reported higher levels of career satisfaction in comparison to those physicians trained in Spain.
Oh.
One of the very interesting findings was that physicians who received non-monetary incentives were had a higher level of career satisfaction than those who didn't receive this type of incentives.
And what kind of incentives are non-monetary for physicians, like time off or...
Non-monetary incentive refers to having time to access to training or support when publishing a research or time off to accommodate. So those kind of incentives.
Huh. Where did you take your research after that?
So after that, I decided to come with my wife to Canada, and then we completed a survey among physicians practicing in the former Saskatchewan Health Authority. And I evaluated the impact of alternative payment plans versus the traditional fee-for-service.
And what did you find?
We found that physicians paid by alternative payment plans perceive higher professional equity in comparison to those paid by fee-for-service, particularly family practitioners. In addition, we identified lower levels of daily distress among physicians paid through alternative payment plans. And there was an interesting finding about how female physicians had poorer well-being indicators in comparison to their male counterparts, and that the impact of alternative payment plans on professional equity and daily distress was only present among male physicians. So you can see that the benefit that payment models have might be more beneficial for male physicians.
Yeah, and we've largely, for family physicians, we've actually undertaken a plan where now we will make those alternate arrangements. We're moving away from fee-for-service.
Yes, that's the move that needs to be happening. Explore alternative payment plans. They are not prescribed for all situations, but there are specific environments and situations where this model of payment need to be promoted. So, completing my doctoral studies, I wanted to go back and have more involvement with patients and do clinical research. So I started working with the Department of Medicine as a research coordinator, and I had the opportunity to be involved in multiple projects and learn about the inflammatory bowel disease.
Well, yeah, because as a physician, you'd never seen it before in Colombia?
Right. So I knew about Crohn's disease and ulcerative colitis as autoimmune conditions of the gastrointestinal tract, but I never had the opportunity to see or interact with a person diagnosed with this condition. So I got involved in different projects, exploring innovative models of care for individuals diagnosed with this chronic condition.
For people who are sort of more general listeners, what really makes IBD stand out? Like, what is it about inflammatory bowel disease that is troublesome for the people who are suffering from it, especially here in Saskatchewan?
Well, inflammatory bowel disease, including both Crohn's disease and ulcerative colitis, the two main types of this current condition, is an idiopathic and incurable disorder that causes inflammation of the gastrointestinal tract. What it means? That the symptoms of inflammatory bowel disease are variable and can include diarrhea, vomiting, rectal bleeding, abdominal pain, weight loss, and malnutrition. And a person who is diagnosed with inflammatory bowel disease and the condition is not under control could affect their quality of life, could end up requiring a lot of care and hospitalizations and surgeries. So really it's a condition that once you get the diagnosis, you need access to care, to specialized care.
You have to stay on it too, because it's not like it's ever going to go away.
Exactly. The disease can be under control by itself or with the help of some medications and some management, but access to care is essential to monitor the disease. And interestingly, Canada has one of the highest prevalence and incidence rates worldwide. One of the highest numbers of individuals living with the disease or newly diagnosed with the disease. We don't know the reasons why Canada has this, and this is a condition that is common among high-income countries.
But it doesn't just affect people with high incomes. It affects all sorts of people, doesn't it?
Yes, this is a condition that doesn't only affect individuals of high socioeconomic status or certain profiles. Any person could be diagnosed with inflammatory bowel disease. And being a research coordinator and then during my postdoctoral fellowship, I had wonderful opportunities to listen to lived experiences. And through that journey, I heard the voices of many individuals living with this condition, about their experiences with the healthcare system. And there were two very important moments for myself. The first one, when I was presenting one of the results of our studies to a group of volunteers and members of the Crohn's and Colitis Canada, the Saskatchewan chapter, and during that presentation, they made a lot of questions about the project. It was specifically to my postdoctoral research, where we evaluated the impact of an integrated model of care. And they asked me if I knew the data of what's going on of IBD among Indigenous peoples. It was a really interesting question, and I answered that I didn't have details about it, that it is known that lower rates have been reported among Indigenous peoples, but there was not much research in Canada and worldwide. In addition, I started listening to the voices of Indigenous persons living with IBD, the struggles with the healthcare system and how they encounter racism or barriers, or that they had to advocate for themselves, or even educating their primary healthcare providers about what it's IBD. Hearing those narratives and the need of research motivated me to bring together a group of researchers, Indigenous and non-Indigenous researchers, Indigenous persons living with IBD, to form the IBD among Indigenous peoples research team. We were able to use administrative health databases to know how many First Nations with IBD are living in Saskatchewan, how many are diagnosed every year, the trends over years. And we were able to answer questions that were not in the literature before. For example, we learned that IBD is increasing among First Nations in Saskatchewan, the number of people living with IBD. although that the number of individuals diagnosed with IBD appears to be constant during the last 20 years. So the same number of individuals is diagnosed every year.
But a growing number of those individuals being diagnosed happen to be Indigenous.
Yes, the rates of Indigenous persons living with IBD is lower than the general population, but it's still growing just like we are observing the general population.
Interesting.
So that was a new message. At the same time, based on the lived experiences of First Nations and Indigenous persons living with IBD, we compared healthcare utilization with IBD and individuals with IBD from the general population. We identified that First Nations with IBD had fewer medication claims and a higher risk of hospitalizations due to IBD.
Wait, so they weren't using as many prescriptions, but were way more likely to end up in the hospital with complications. So like toughing it out.
Exactly. So it's a narrative. They're experiencing barriers to get access to the right medications outside of the hospital, and they have to arrive to the hospital to get the care they need. That talks about inequities that we also identified between individuals living in rural communities, in the general population, and those in urban centers. So in addition to those disparities in healthcare utilization among First Nations, we were able to observe in the general population that individuals diagnosed with IBD and living in rural areas had fewer gastroenterology visits, lower likelihood to having a gastroenterology as the primary IBD care provider, lower rates of endoscopies, a necessary procedure to be able to see how is the disease going, and they had a higher risk of IBD-related hospitalizations. So the care the individuals in rural areas and urban areas are getting is different.
The main difference is they're still using medications, but they're less likely to be under the care of a gastroenterologist as their primary. It's more like probably a family physician somewhere.
Exactly.
Who may or may not have expertise. More likely to be hospitalized.
Yes, that's right.
So things are likely to have gotten out of control.
Exactly.
And it just sounds like a general lack of support if you don't happen to live in a bigger city.
Mm-hmm. So having access to a gastroenterologist and an IBD specialist is critical for having the disease under control and monitor it. So these studies talk about the need of innovation in the way that IBD care is provided.
Because up to now, if you want to see the gastroenterologist, you have to get a referral, you have to sit on their wait list for a while, then you get an appointment and they get to meet you. But it's not like you can just text the doctor when you're feeling bad. Like even just getting another appointment can be very tricky. That's right. So what happens?
So that the pandemic was a good opportunity to start exploring ways to innovate care. We completed another study where we evaluated the factors associated with telephone care that is one of the forms of virtual care.
Just talking to your doctor on the phone.
Exactly. So, and with this, we identified that individuals living in rural residence, in comparison to those in urban areas, were more satisfied with telephone care.
And was telephone care the only method that you looked at for this one?
In this study particularly, yes, because in Saskatchewan, that's one of the main forms that has been used. Telephone care is not for all situations, but if you have your disease under control, you are following up medications, doing some lab work, basically connecting with your gastroenterologist to check how are my labs, how I'm doing with the medications, and checking that everything is going well will be enough. And having that regular access is critical instead of needing to commute to the city, be in the waiting room, and the extra cost of that you have to stop doing your job, you have to stop doing farming, you need to look for options how to look after your kids. So telephone care is one of the options of virtual care that needs to be promoted in certain settings. But if the condition is not under control, definitely you need to come and be able to get exams and interact in person with your gastroenterology care providers.
Well, that's really good news. And I could see a case being made for, yes, let's move towards this, because if you can keep people with inflammatory bowel diseases in sort of maintenance mode, maintaining good health, then you're not going to have the rush to surgery. You're not going to have emergency room visits. It's just, it should cut costs in the big picture, shouldn't it?
That's right, yeah. And that's the need of innovating care is not restricting care to being only telephone. It's to identify ways how care can be improved. And that's one of the studies that we're currently doing.
Oh, okay. What's next for you, or what's on the horizon?
So we are focusing right now into specific groups, those with Indigenous background and those living in rural Saskatchewan. So we are conducting a study right now that is funded through the Saskatchewan Health Research Foundation, in which there are 2 patient navigation interventions. Those could be peers, or could be a health professional, for example, a nurse, doing navigation to individuals with a chronic condition.
Oh, like having specific people who are kind of steering you or helping you through.
Exactly, guiding
navigating you.
How to navigate the healthcare system, understanding the treatments, have access to information, connecting with this person on a regular basis. And if there is something that is wrong, this person could activate a follow-up with the gastroenterologist or the primary healthcare provider. And having a peer navigator, for example, could help a lot to have access to, for example, to traditional medicines, or understanding better certain exams, getting the support from a peer who has the disease and have similar experiences, so could get the support and be able to talk about it and how to go through.
It's the buddy system.
Yes.
That makes so much sense. How many people are you recruiting?
So we are expecting to recruit 100 persons living with IBD and living in rural Saskatchewan, and we are going to compare their healthcare utilization and patient-reported outcomes before and after interacting with the nurse navigator.
And are you going to do interviews with them as well?
Yes, so it's a mixed method approach. We are using medical charts, the online service, but at the same time, we are going to have individual interviews with each of them to understand better their experiences interacting with the nurse navigator.
And what do you think you're going to find?
We expect to observe an improvement in patient-reported outcomes. We expect to see a reduction in hospitalizations, likely an increase in interactions with gastroenterology healthcare professionals, fewer negative disease outcomes, for example, hospitalizations, emergency visits. We expect to see changes in the levels of anxiety, as well as health-related quality of life. And those are the aspects we are measuring in this study through the surveys.
I'm so glad that you're doing this. Thank you so much for being our guest here on the podcast.
Thank you very much, Jennifer, once again.
Dr. Juan-Nicolás Peña-Sánchez grew up in Colombia and followed in his father's footsteps as a physician. From there, he moved around the world, most recently to the College of Medicine here at the University of Saskatchewan, where he's an associate professor of community health and epidemiology. He studies inflammatory bowel disease, its prevalence, incidence, how you can access healthcare for it, and the best models of care. He's a member of the Inflammatory Bowel Disease Research Collaborative Network and the IBD Among Indigenous Peoples research team. And he is Saskatchewan's lead on collaborative national studies initiated by CanGeek. That's the Canadian Gastrointestinal Epidemiology Consortium. You can see more of Dr. Peña-Sánchez's work at medicine.usask.ca. Researchers Under the Scope's a presentation of the Office of the Vice Dean of Research at the University of Saskatchewan's College of Medicine. We record this podcast on Treaty 6 territory, and we pay our respect to the First Nations and Métis ancestors of this place, reaffirming our relationship with one another. This is also where I'd like to thank you for tuning in. I'm Jen Cannell, your host, and if you like staying up to speed on what's happening at the College of Medicine and on biomedical research, find those little dots up in the corner, follow show, and you'll get all the latest episodes of Researchers Under the Scope.